This podcast is recorded in the land of the Kaurna people here in Adelaide. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members and trainees live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This podcast is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced and evidence-based discussion. When a medication is mentioned, we will use the generic name unless referring to a medicine listed on the PBS, in which case we will use the commercial name. Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at RANZCOG guidelines, ANZCOG research, and the latest innovations shaping clinical practice in obstetrics and gynaecology. Through expert-led conversations, we unpack what's changing, why these changes are important, and how they're influencing women's healthcare across Australia and Aotearoa, New Zealand. And members of RANZCOG CPD Home can listen to the RANZCOG podcast to claim hours towards their requirements. I'm your host, Dr Heather Waterfall. I'm an obstetrician and gynaecologist based in South Australia. In this episode, we sit down with endometriosis expert, Associate Professor Mathew Leonardi. Mathew is a nationally and internationally recognised leader in gynaecological surgery and ultrasound. He's an Associate Professor at McMaster University Medical Centre in Hamilton, Canada, and holds a PhD from the University of Sydney, which was focused on the utility of ultrasound in the diagnosis and surgical management of endometriosis. He's an honorary adjunct lecturer at the University of Adelaide. An avid researcher, Mathew is currently involved in numerous local and international projects on endometriosis, ranging from studies on pathophysiology to assessment of surgical outcomes. He has authored over 100 peer-reviewed scientific articles and several textbook chapters. As a sought-after speaker on endometriosis, he has presented at major international congresses, including most recently the RANZCOG Annual Scientific Meeting. Mathew sits on the World Endometriosis Society Early Career Board and is a founding member of the Next Generation Committee at the International Society of Ultrasound in Obstetrics and Gynaecology, amongst many other prestigious appointments. As a sought-after speaker on endometriosis, he has presented at major international congresses, including most recently the 2025 RANZCOG Annual Scientific Meeting. Mathew has a number of disclosures that he has listed in the show notes. In this conversation, we'll be putting RANZCOG's members and trainees questions on endometriosis to Mathew for his insights. Mathew, welcome to the podcast.
Thank you, Heather. Thank you to the RANZCOG podcast team, and thank you to RANZCOG overall for the invitation to the recent RANZCOG ASM. I had a beautiful time here in Adelaide, and I'm so happy to be able to contribute to the knowledge growth in Australia.
Oh, fabulous. Thanks so much. It's so good to have you here. Just before we begin, it's worth mentioning this episode complements episode 4 of Talking O&G, which unpacked RANZCOG's new Australian Living Evidence Guideline on endometriosis, which has all the key updates and evidence and their impact on clinical practice. So if you haven't listened yet, I'd encourage everyone to check it out for a more holistic overview of what's changing in endometriosis care, and the link's in the show notes as well. Mathew, let's start. Let's talk. I want to start with the shift towards ultrasound as the preferred first-line diagnostic investigation for endometriosis. There was a little bit of criticism about the Living Evidence Guideline that we focus so much on ultrasound in diagnosis. So we're going to talk a little bit about laparoscopy soon, but talking ultrasound first. It's a key development in the guideline, and it's a central area of focus in your research and practice. So can you talk us through what are those key developments and how have we changed towards ultrasound being so key in the diagnosis of endometriosis?
Interestingly, ultrasound has always been there. Not always. I mean, it was invented in the probably 50s or 60s, and within the space of obstetrics and gynecology sort of arose in the 80s and 90s. But it has been there for many, many years and has been looking at gynecologic organs for many years. But it has been looking at the pelvis with a rather narrow view, only looking at the uterus and the ovaries. And when you only look at those two structures, you miss so much more. You miss mostly where endometriosis exists, in the posterior compartment, which is the area behind the uterus. And you only get the tip of the iceberg when you see an endometrioma. And so we have realized that if you look outside of the classic uterus and ovaries view, you can find endometriosis. And for now many, many years, probably over 20 years, we've known that you can identify deep endometriosis on ultrasound. And the research and the evolution in guidelines has really progressed to be able to refine that based on anatomical location, the bowel, the ligaments, the bladder, as some of the more common locations. And then we have moved forward to understand through dynamic maneuvers, whereby we push with the probe, we push with our hands, you can see adhesions, which is when organs become glued together. And that's a really common finding in patients with endometriosis. And that has lots of utility in understanding the stage of the disease and surgical complexity. But now we have even evolved further to find the most tiny lesions, those that are 1 millimeter, 2 millimeters in size, called superficial endometriosis, which was a very large portion of my PhD taking place here in Australia and originally published in 2020, the direct visualization of the third subtype of endometriosis, superficial endometriosis. So we have seen lots of steps over the past years, allowing us to know we can see all forms of this disease. And that's allowed us to diagnose people non-invasively, moving away from that laparoscopy as the diagnostic test and allowing laparoscopy to remain as a therapeutic intervention when deemed necessary.
But if we're going to do a laparoscopy anyway, why do we need a good quality ultrasound before that laparoscopy? Is it over-investigating?
Absolutely not. It starts off with a conversation with the patient around whether to do surgery in the first place and figuring out, well, what are the symptoms and what are the diseases behind those symptoms? And there's lots of overlapping conditions within the pelvis that contribute to the same symptom complexes, such as adenomyosis and hemorrhagic cyst formation. And there's other gynecologic issues that could be playing roles in people's symptoms. For example, people with PCOS often have prolonged, heavy, more painful menstruation. And that could be interpreted as possibly endometriosis, but actually you need to know about whether PCOS is present before a diagnostic or a therapeutic laparoscopy, because the patient has to have an opportunity to know about what's in their body to decide whether they want to pursue that surgery. But beyond the whether to operate, you also want to determine who should operate. And endometriosis, I think it's very fair to say, we know this across the world, is a very difficult disease to manage surgically. And most of our training programs across the world don't actually allow the graduating OBGYNs to tackle this disease in the way that we now know it should be tackled with it, which is excision of endometriosis. And so if you are trying to figure out whether you should operate, you need that preoperative assessment sonographically or potentially through MRI, which we can talk about as well, in the absence of advanced imaging techniques locally in your center. You want to know, should I be the person to operate on this patient? And we can get into even the more granular aspects, but if there's a bowel endometriosis nodule, well, most gynecologists are not tackling that on their own, so they need to call their friends, their colorectal surgeons. And so you need to know beforehand. You can't do a diagnostic laparoscopy and then say, oh man, this is way too advanced. I have only booked this case for 2 hours and there's no way I can do it in 2 hours. Or identify an obliterated pouch of Douglas and abandon. That's not fair to you. That's not fair to the patient. That's not fair to the health system. And it's costly. So there's so many reasons why the preoperative assessment is essential. You know, it's a bit bold to say, but I think if people are still believing that diagnostic laparoscopy is sufficient and they don't need that preoperative map, they're a bit out of touch and they need to really evolve.
I think that's a very good point in terms of looking at our health dollars, that the investment in an ultrasound prior can actually claim back so much more benefits in terms of how we plan our surgeries.
Mm-hmm.
As you touched on before, in Australia, we now have expanded Medicare funding to support the use of MRI scans to investigate endometriosis. How do you think MRI compares with ultrasound in its ability to detect endometriosis, superficial endometriosis, but also that more important obliterated pouch of Douglas as well?
Mm-hmm. So if you're thinking about this from a diagnostic lens across the different domains, the different subtypes of endometriosis, I think ultrasound actually has an advantage because it does have the ability to rule in superficial endometriosis. We can't rule out superficial endometriosis with ultrasound. MRI, generally speaking, cannot really rule in superficial endometriosis. These lesions, again, are 1 millimeter in size, sometimes even smaller. I don't usually measure them when I find them on scans because they're just so small, but I have in the past, and they can be 0.5 millimeters. MRI slices are not usually that narrow. They're more 2-3 millimeters, so you can totally miss even a deep endometriosis lesion. And so I think ultrasound has an advantage when it comes to superficial endometriosis. But when you look at the systematic review meta-analysis literature on ultrasound compared to MRI for deep endometriosis, they're quite head-to-head. And when you really look at the high-value types of lesions like bowel and bladder lesions, they're very head-to-head. So if you are thinking about this a little bit more pragmatically in centers where advanced ultrasound may not be accessible yet, MRI is a fantastic tool that should be used to make sure that if you're going to get into this case, you want to know, is there a bowel nodule? And if so, you talk to your patient about it. They need to consent to a bowel surgery. The colorectal surgeon needs to be part of that picture. So I think when you have them head to head with the literature, they're both very good. And you should use one. Ultrasound, generally speaking, has more affordability to it from an overall technology perspective. And so that's sort of the first line. And I think in most gynecologic settings, kind of regardless of what pathology you're assessing, ultrasound is still the first line. So you're never going to see a patient in the office and not have an ultrasound and then go straight to an MRI. So the patient's going to end up having an ultrasound anyway. And if you have access to it being an advanced ultrasound, make it that one.
Yeah, definitely. Access to good quality endometriosis-specific ultrasound is still limited, whether you're in a tertiary centre or in a rural centre. I think we still all struggle getting access to good quality ultrasound. From your perspective, how can we train more people to better perform these scans? Is it possible to upskill more gynaecologists to learn these skills, or should we be relying on sonographers and radiologists to provide us with the image quality that we need?
I really think at this point in time, it's key that we consider all possible avenues, all possible team members, because we need volume. We need people to be doing this. Right now, we are quite limited. And so we shouldn't focus on a singular group. And I think our educational efforts should target gynecologists, sonographers, and radiologists as individual domains. And my goal, I have a sort of career aspiration, is I want ultrasound to be in the hand of every gynecologist, and in particular, every gynecologist who's doing endometriosis surgery, because it has revolutionized my approach to gynecologic surgery for endometriosis. Being able to see things sonographically and surgically is what I consider to be a superpower. When I'm scanning, I think surgery. When I'm operating, I'm thinking ultrasound, and it gives you two views of the exact same thing. It's enhanced my knowledge of anatomy, both normal and abnormal planes that I need to get into for endometriosis surgery. And I could not imagine not having this skill set when I'm tackling an endometriosis surgery. So I think any gynecologic surgeon who's tackling endometriosis surgery, the probe should be in your hand. That will change the game for endometriosis outcomes, I have no doubt. And I look at colleagues who are close to me at home who are not scanning, which is actually quite standard in Canada and across most of Australia as well. Most gynecologists are not scanning. And, I think most of us we are all absolutely trying our very best. We're trying really hard. We want to do good for our patients. Nobody ever wants to do harm or be not the best they can be. And I've had colleagues in Canada who have had initial hesitation to this idea. I kind of came back to Canada after my PhD and fellowship here in Australia, a bit like a wrecking ball, and said, this is really bad, guys. Like, we need to be scanning everybody. You cannot do a laparoscopy without the preoperative map. And many very good surgeons said, nah, I'm okay. I know how to find it surgically. And so very recently, a good friend of mine now, she came and spent a day with me at my ultrasound clinic. She's one of Canada's best minimally invasive gynecologic surgeons. And a patient had a bladder nodule and a lot of other things going on too. She brought that patient to theater the following week. And she messaged me right after. She said, if I didn't know from you there was a bladder nodule there, I would absolutely have not known that the bladder nodule was there. And I would have done an incomplete excision surgery for this patient. So when we're going in, our goal is take out whatever is there that, you've chatted with the patient about and they've consented to. If you don't know it's there, you're leaving it behind, not knowing it's there, thinking you've done a complete job. And if that patient's hematuria or bladder symptoms continue, you might think, oh, well, it must be a urologic issue and not an endometriosis issue. So I really think we need to shift the focus to the tool should be in the gynecologist's hand primarily. And that's where my educational efforts are heavily focused. But we cannot do this alone. We know that most general radiology practices are scanning a majority of gynecologic patients. We need to train sonographers. We need radiologists as collaborators. They need to know about this disease, not just from an ultrasound standpoint, but they need to know about it from an MRI standpoint as well. So we should try and be really quite strategic about teaching and how the teaching can be customized to the different groups, because they will need a specialized approach.
I like it. And I think maybe hopefully the RANZCOG curriculum people are listening in a bit as well, to add the role of advanced gynaecological ultrasound to actually not be quite such an advanced skill, but actually a skill that we should all be attaining, ideally in our training.
Quite a few years ago, I did a review of curriculum across the world, and not very much is published openly in different countries. So it was Canadian, American, Aussie, and New Zealand curriculum literature that I was able to find, actually a bit of UK. And when you look at what is required for a graduating O&G resident across the world from a gynecologic ultrasound standpoint, it's either absent or incredibly minimal. And it's actually often more in the early pregnancy space.
The early pregnancy scanning, that's how we learnt transvaginal scanning, is in the early pregnancy space.
Which is relevant and important, but it's nothing to do with abnormal bleeding, pelvic pain, ovarian, cystic lesions. We graduate knowing none of this, and we are responsible for operating on all this. And I don't know what it's like so much across Australia, but I can say in Canada, incredibly rare for a gynecologist to open up in theater the ultrasound pictures and look at them themselves. Most gynecologists, if you said, here, look at these pictures, they would have no idea how to interpret them. And if you think about most other surgical specialties, and I reflect back on my residency years, they always have the images open up in theater. They know how to look at pictures right before operating. Meanwhile, as gynecologists, we're relying on a paper report with words from a radiologist who does not understand the pathology like we do, and has maybe never even actually seen that patient themselves, because again, we have the technician sonographer role. And so, I think we need to take the probe.
I like that. That's going to be the overarching message for this episode, I think, is we need to take the probe in our own hands. Moving on more to a laparoscopic focus, but how do you manage endometriomas, and in particular for those women who are seeking fertility? We had a bit of a discussion at our last episode about endometriomas and AMH and the impact of our surgical approaches to endometriomas, and I'd love to hear your take on this. Yeah,
this one's a challenging one, because you have to first look at the context. Are we talking about a 22-year-old with an endometrioma, a 35-year-old actively seeking a pregnancy? Most 22-year-olds are not at all, or a 45-year-old, right? And we also have to take into account some recent literature. I mean, for a long time, we've known about associations to certain ovarian malignancies, so that has to factor into it as well. But I think the context is key. And current priorities and future priorities are key in order for us to frame the discussion. When it comes to a surgical standpoint, I think it's so important. Top message from this podcast is an endometrioma is almost never in isolation. So if you're thinking, I've seen an endometrioma on a scan or an MRI, and I haven't had the advanced imaging report on deep endometriosis or superficial endometriosis or adhesions, and you're thinking, I might take this patient to theater for an ovarian cystectomy, stop. Think again, because it is incredibly rare for an endometrioma to exist in isolation. Most of the time there is deep endometriosis, and the most common associated site is the uterosacral ligament. And even if you're a fantastic surgeon, if you go in and you peel that endometrioma, that ovary that's stuck to the pelvic sidewall and USL off, you can't see the lesion that's deep within the tissue. And again, people will leave things behind without knowing that they've left things behind. So don't book a patient with an endometrioma for a cystectomy without, on the consent form, excision of endometriosis. And in cases of more advanced disease, you may have concurrent laparoscopic low anterior resection or discectomy or bladder cystectomy. So those pieces need to be part of it. But when you are integrating endometriomas into surgery and you are thinking, okay, should I take this out or not? What procedure should I do? I think fundamentally, preoperatively, these patients deserve at least a conversation with a fertility specialist if they are future seeking or actively seeking. And some recent literature out of Canada would suggest that high volume endometriosis surgeons have a higher referral rate to fertility doctors before surgery to give people a chance to have that conversation. It's never a commitment. You don't have to do egg freezing or embryo freezing, but they deserve at least a chance to have that conversation, understand what's involved and whether they want to do that or not. And so I do that all the time. And of course, checking AMH I may do, or if I'm referring to the fertility team, I may let them do that. And then I think you have to talk with the patient about what should we do to this endometrioma and when should we do it. So sometimes people will do egg or embryo freezing first, followed by surgery involving cystectomy, and then embryo transfer thereafter, if it's something that they're actively seeking. And if they're not actively seeking it, then cystectomy on its own. I don't do any other procedures of like ablating or vaporizing the endometrioma surgically. I do think cystectomy is the right thing because otherwise it will for sure come back. Although even with cystectomies, I think recurrence is sadly a high rate. Mm-hmm. But the more recent thing that we've started to look at, and there's a decent amount of literature from the past and some growing present literature, is ethanol or doxycycline sclerotherapy to offer people an alternative where we may be able to remove the content and try and essentially burn the interior of the endometrioma to permit attempt at natural conception or optimize the fertility journey if, for example, the access to the ovary is challenging, right? So we've started to think about that a little bit, as well as an ultrasound-guided procedure that could be in the toolkit.
I like it. All good things to consider before we're getting into starting to operate. On the other end of the spectrum, talking about women who have a negative ultrasound. So the Living Evidence Guideline suggests if there's no improvement using hormonal treatment in women with normal imaging or for women who don't tolerate hormonal treatment, we can still use laparoscopy for diagnosis and excision if we find endometriosis. What do you think the value is for those women who have normal imaging, even with an expert endometriosis ultrasound?
I think that's a really important message. I'm glad the guideline emphasizes that we cannot rule it out at this point in time, and maybe we will never be able to rule it out, even with advanced imaging techniques. I'm hoping that something else other than surgery will help us fill that gap, like biomarkers, for example, blood, saliva, menstrual fluid. Maybe those will help us fill the gap, in particular in those with a negative imaging test. So that laparoscopy, again, could be used from a therapeutic standpoint. So when I have a patient who has a negative ultrasound and we're talking about treatment options, I always bring myself back again to understanding, is endometriosis the most likely diagnosis here? Yes or no? And is it the most likely player in their symptom complex? Because there are so many others. And we want to make sure that our treatments are targeted to what is the largest pain generator, primary pain generators. And so lots of people have myofascial pain as a huge component, and excision of endometriosis is not going to fix myofascial pain as a pain generator. And so if I think that that's the primary generator of this patient's pain, then laparoscopy with excision of endo, should it be identified, could be part of the treatment puzzle. But if patients rely on that as the sole part of the treatment puzzle, they will fail. They will be disappointed. I will be disappointed. So I really try and take that step back and identify as many of the pain generators as possible, identify how contributory they are to that patient's quality of life, their symptom complex, and then identify which treatments are going to be the best aligned to that. And it could be that laparoscopy with excision is one of them, or laparoscopy with excision and hysterectomy if their uterus is a player, with adenomyosis possibly. I mean, in that case, it wouldn't be a negative scan, but negative from the endometriosis perspective. And I think we have to stop ourselves from oversimplifying endometriosis. I see this in both the lay population, but also amongst OBGYNs across the world. It would be really nice if it was so simple, if endo was the primary and only cause and we just had to go in and cut it out and everything would be fine, but that's just not the case. And we know that from history because the reputation of endometriosis surgery is well published. People still have lots of symptoms and poor quality of life after. So we've missed something. And I think it's all those pain generators that go together that we really need to start targeting. But I do laparoscopy for people with a negative scan when I think the laparoscopy is going to be a helpful therapeutic part of their journey.
No, that is a very good way of explaining it to women. I think part of our consent process really needs to be for women who've got negative imaging for endometriosis is that potentially their laparoscopy may not help their pain, and definitely in the short term it may worsen their pain, especially if they have central sensitization and myofascial causes of their pain, that laparoscopy may actually trigger worsening of their symptoms in the short term, and they need to be aware of that as part of their consent process.
Exactly. And I don't know how many gynecologists are really having the risk side of the conversation. You know, we want to go in and find it and give people a diagnosis and hope that taking it out helps, but there is a downside to it. And it's not just the pain downside, but other risks of surgery, obviously, as well. Bleeding, infection, organ damage, you know, it's not so innocuous. So they need to be in control of that. And I think if you can really ramp up the conversations around validation, even with a negative scan, and if their symptoms align with endometriosis, you can say, this is what we would call a clinical diagnosis. You know, I know when I write about this or talk about this in presentations, I don't love it because I think we should try our very best to find it in very reasonable, safe, cost-effective ways. But I think there is a place for a clinical diagnosis if the symptoms align, and you can then attach therapies to that. And it may still involve a laparoscopy, but we're not talking to people about the negative effect of laparoscopy as a pain generator in and of itself.
And I think we talked a bit earlier about prehab prior to surgery, and I definitely try to perform prehab for my hysterectomy patients because it is such a major undertaking to have a hysterectomy, even if it is a laparoscopic approach, and valuing the preparation that women can do, whether that's looking at central sensitization and other medications like amitriptyline we can institute preoperatively, and also things like getting bowels and pelvic floor spasm well, or at least attempting to get that under control before we even talk about doing a laparoscopy, knowing that they'll be worse after surgery.
Yeah, I often integrate all of these interdisciplinary or allied healthcare professional associated treatments from the first consultation. I love that in Australia, the concept of prehab is a growing concept and rehab post-op, because most of our surgeries are quite large and invasive. And it's interesting that in a lot of other surgical specialties, it's already integrated. I learned that at one of our hospitals in our city, if a patient has a major abdominal surgery, the physiotherapist will come to see them post-operatively on the ward. And our OBGYN patients are not included in that, including those who have a cesarean section. That is a major abdominal surgery. And the physiotherapists do not go visit that particular patient. And I immediately messaged the head of departments in both of the hospitals. I was like, is this really happening? Like, have we just missed the mark on this? And so I think that we really do need to start ramping up the conversation that surgery is an event that disturbs muscles and nerves, and, you know, you slow down after. We were also talking about movement as medicine right before getting started on this, and you need an approach to this. And so I really love that it's a focused conversation, but I try to bring in as many of those complementary and alternative treatment processes long before the concept of prehab from the first visit, because these other systems that are there, the muscle system, the GI system, they require that approach. That's the right therapeutic approach, because surgery is not going to fix those things. Medications are often not going to fix those things in the way that we would love, because it's simpler. It's just not reality.
Yeah, no, we would love our operations to fix this pain, but most of endometriosis pain is complicated pain and comes with other pain generating conditions that we have to address before we expect that a laparoscopy will fix their pain. I wanted to ask about recommendations for repeat laparoscopy. I have women return sometimes years after their first laparoscopy, or they've had laparoscopy with another provider, and they request further surgery. What do you think are the specific indications or suggestions as to who and when should have a subsequent laparoscopy?
Very good question and quite controversial. I know I saw quite a lot of repeat laparoscopy when I was spending time here in Australia, which I don't see as much in Canada. We have different health systems, although there's overlaps in similarities, but we also have differences that I think drive some of those changes in practice across the two. So when I see a patient who has had a surgery, who's now coming to see me, whether they're my patient or somebody else's patient from before, I try and always take a fresh look at what are the pain generators. Is endometriosis an active pain generator? And we use imaging to try and help us with that, although there hasn't been that much literature yet on what it looks like for a patient who has undergone surgery to assess their pelvis with imaging. But there's some instances where it's quite easy to interpret. So if somebody had an abandoned laparoscopy and nobody has really done anything, then there's no real operative effect of that to then change the interpretation. If somebody has had a hysterectomy without excision of endometriosis, and you hear things like, oh, we might have had to leave the cervix behind because it was densely attached to the bowel, that gives you clues as to what was in that patient's pelvis before that you may be seeing now. So again, it's how you interpret that imaging in the clinical context. So you really have to figure out what is the primary driver of the patient's symptoms right now. Another really important question to ask is how people did post-operatively. If they had surgery 1 year ago and they got better for 3 months or 4 months and now they're back to their baseline, it's highly likely that endometriosis is not a player. And it's the other pain generators that were temporarily subdued either because of the anesthetic, the muscle relaxants, I don't want to call it the placebo effect because I don't think that's the right term, but I have this saying, diagnosis is therapy. And for some people who have pursued a laparoscopy where the diagnosis is achieved at that laparoscopy and they wake up and they learn about what their diagnosis is, that has an immense therapeutic value. The other thing that I think has an immense therapeutic value is somebody operated on me and therefore they believe me. And that hugeness of surgery as an entity, as a therapeutic entity, means that they really believed me. They didn't just believe me and they prescribed me a medication. They really believed me that my pain is real. And they're doing this what is perceived to be invasive. And in some cases within the patient population, there's even this concept that doctors are gatekeeping surgery, but this doctor didn't gatekeep this. So they must really believe me. And I think that has an immense psychosocial therapeutic value. So all these things together, the anesthesia, the belief, the maybe temporary relief from excising some endo, all carry this sort of positive effect that lasts for several months, and then those wear off. And then the other pain generators that are present, whether that's menstruation, adenomyosis, hemorrhagic cyst, myofascial, IBS, those start to rear their head again, and they're not well. And so then they go back for another surgery, maybe with somebody who's not so, nuanced in their assessment of them, and they get that temporary relief again. Mm-hmm. And so I always ask them, what happened after your surgery? How long were you well for? And that then allows me to understand, well, do I think endo is a generator or is it not? And if it's not, sorry, I wish again surgery would help you, but it's not. So that's my way that I sort of break this down, and I try to figure out whether somebody's a good surgical candidate or not.
When we talk a bit about ultrasound and the differentiation between mild, moderate, severe endometriosis on ultrasound, for women who've already had a laparoscopic excision of endometriosis, how do you differentiate old scarring, old endometriosis, new active endometriosis on ultrasound? It's
really difficult. So if they've had a proper excision surgery, or if I've operated on them and I know that I've excised everything that I had previously seen on the imaging, then I try to, there's some that are actually really easy. So endometriomas, these are really easy to determine recurrence. And I think they're actually one of the more common types of endometriosis that recur. And I've seen that in my own patients, in other people's patients. There's no question about endometrioma recurrence. Deep endometriosis, I think, is a really challenging one because a lot of deep endometriosis, particularly within muscular structures like the bowel or vagina or bladder, have a fibrotic aspect to them. And that can look the same as postoperative fibrosis. So I really struggle to be honest. And we don't have good literature on whether something that's seen postoperatively is endo or not. And so we need more research on that. I think superficial endo is probably the most difficult, though, because if somebody only had superficial endo and somebody has done a peritonectomy or excision of lesions in multiple locations, you would expect that tissue to have some irregularity in appearance. And so you have to be really cautious when you see these features to not say it's superficial endometriosis, but rather it's irregularity of the peritoneum that could be superficial endometriosis or could be postoperative changes. I think that's really important now because we are at the point in time where lots of people are learning ultrasound. And what happens with any imaging test when you start to learn is you see things that are not real. And then a patient may feel validated, they have a recurrence of superficial endometriosis, then they might think I should pursue a laparoscopy to excise it. And then the surgeon goes in and says, hey, you don't have any endo, or the histology comes back negative. And then they feel like, well, the imaging misled me. But there's nuance and caveats to imaging. There's nothing that's perfect. Even surgeons are not perfect. Histology is not perfect. And so I think we have to be really delicate right now, in particular in those who have had surgery before, to not rely on imaging as the pure diagnostic test and interpret everything in the whole context.
No, thank you for that. I really struggle, I think, with those women who've had a previous laparoscopy and then they come back in. And if it's 5 years down the track and they've had IVF and they've been pregnant and they're breastfeeding and their pain has recurred since their family is complete, it really becomes a more nuanced conversation of the aim of laparoscopy.
Yeah.
But in those women, especially if their family is complete, then there is a role for another laparoscopy. Remove their tubes as well as a therapeutic effect of a laparoscopy. And at the same time, we can look to see, is that imaging really true? Is it endometriosis or not? A
really interesting thing happened recently. A couple months ago, I was in my scanning rooms and a patient arrived and I was like, I know this name. And then I looked up her record and I had just operated on her 4 weeks ago, but I wasn't expecting her to come for a scan. And so she actually had a scan planned, but then her surgery got moved up. And so she had her surgery, which was excision of endo. And then she still came for the scan because she thought she had to come for the scan. I would have, if I'd known, I would have said, don't come for the scan. We never scan people 4 weeks post-op, but she was there. And also, for context, in Canada, it's all publicly funded. So, she wasn't out of pocket. And so I was like, whatever, she's here, I'll scan her. There were lesions that looked like deep endometriosis. And I had just operated 4 weeks ago. And I was like, there's no way. I had the full map before the surgery. She had a scan in the office. And so I was like, what is going on here? So I had read and actually had reviewed a paper that was published by Davor Jurkovic, who's a huge name in the ultrasound space out of London. And their team is proposing that hemorrhagic events within the pelvis could be a seeding event for deep endometriosis formation. And I have been appropriately cynical about this and challenged him in person, who I know quite well, and thought, I'm not sure that this is really what's happening. But then I thought, okay, in a patient who we've just operated on, they are having small hemorrhagic events. We're quite diligent about making sure nothing is bleeding. We do the snake sign test with fluid in the pelvis to make sure that there's no obvious bleeders. But for sure, there's small things that will bleed post-op. The second they move around, something might bleed a little bit. And so I asked him recently, I was like, do we think that in the patient who's immediately post-op, who probably does have endometriosis cells lingering within the pelvis, when we cut tissue, cells spray away, and then they have a small hemorrhagic event, could this be a new seeding event for a new lesion immediately post-op? And he's like, yeah, for sure. And so then I thought, we're really, as surgeons, we can't be 100% bleeding free. That's just not possible unless we, cover the pelvis in some sort of hemostatic agent. But even then, and also who knows what the effect of that is on imaging too.
What's the fibrotic effect on that?
Yeah, exactly. So I thought, man, if this hypothesis is true, if bleeding events become a nidus for a new lesion to develop with cells lingering within the pelvis, then really, like, is there a role for surgery? Or do we need to think about some other therapies that will somehow, I don't know, melt or prevent endo? Maybe a post-operative chemotherapy type situation. I don't know. But it was disturbing to me to scan this patient, and not like upsetting, because, you know, I still will focus for her on whether she does well or not. It's not about the lesions. I think that's a really important thing for us to always remember. You know, when we actually see her in her post-op visit, you know, how are things? And then 6 months later, how are things? That's what's important. But it really is academically disturbing me, because I want to know, you know, is endo newly there, or is this just the usual post-op appearance?
So really tricky if you never scan anyone 4 weeks post their surgery to know what it should look like and what is normal post-recovery inflammatory changes on the ultrasound.
Yeah. So in chatting with him at the recent ultrasound meeting, I was like, okay, I think I need to do something quite bold. I think I need to do a study where I scan every patient of mine 4 weeks or 5 weeks post-op, you know, not immediately the few days following, but, you know, enough time that things have sort of healed over a bit. And it's bold because I could show that maybe, you know, I'm not a good surgeon. Maybe there's lots of lesions that are still showing up. Maybe they're not lesions, who knows? But somebody's got to do this work, because we do need to know what the post-operative pelvis looks like. We need to know how the healing process happens. And so this is a study that we're starting to develop.
We'll watch this space then.
Yeah.
Sounds good. We've focused on the improvements in endometriosis detection and management. More controversial, what do you think are the downsides to all of the increased awareness and screening and discussion of endometriosis? Do you think there is a nociceptive impact on all this talk about endometriosis?
Good question. Very controversial. So one of my talks at this RANZCOG meeting was on social media. And I have learned a lot from patients, both in the office, but I have learned a lot from patients online, both good and the downsides. Endometriosis, for better or worse, sometimes yields an identity. This endometriosis warrior identity. And for some people, that identity actually becomes a career. They become the director of an endometriosis organization. They start charities. They become an endometriosis warrior. And that's not a bad thing. That's a good thing. But the identity of endometriosis that's attached to a person can be quite challenging, because if somebody then doesn't have endometriosis anymore after surgery, is that identity the same? And so I think the issue with diagnosing comes to how much people put the emphasis on the endometriosis as the identity, or endometriosis as the culprit. And I think our job as clinicians is to help people understand that this is just one thing, one part. And we've talked about this quite extensively already. It's almost never the only pain generator for patients. It is a pain generator, and it should never become the be-all, end-all or scapegoat. And actually, not to reference him again, but Davor Jurkovic and Tina Tellem, they just wrote an article about endometriosis being a scapegoat for people's pelvic pain. And so I think we have to be really careful to acknowledge, validate, diagnose. I think we should be diagnosing. I don't think we need to be delicate women and individuals assigned female at birth that could have endometriosis. These people, they deserve to know, and they deserve to tackle it however they want. But we have to do a good job with educating them on this is one part of you, and there's solutions. So I think diagnosing it early as possible is going to be really key in helping people get on the right track. Susan Evans talked about this at this meeting around the idea that we can probably prevent the development of persistent pelvic pain and central sensitization by getting things right early in a young patient. But I think if we don't do the job well, and people are using endometriosis as a scapegoat, or are using it as an identity, whereby getting better could actually mean that identity doesn't exist, I think that's where the harm can come from. But I don't think we should be the deciders of this. I think we need to do our job as best as possible in diagnosing the disease, validating people, getting them on the right treatment paths. And we can't control what everybody's going to do with it, but we should help guide them as best as possible. What do you think? I'm curious.
I think that you've definitely wrapped that up really well. I think my concern with the nociceptive effect of all this talk about endometriosis is the woman who doesn't have endometriosis but has significant pelvic pain, and the lack of that diagnosis can be devastating for some women, that they are convinced they must have laparoscopy, they must have endometriosis because they have terrible pain. But when they wake up to then say, well, actually, no, your ultrasound was correct, I wasn't able to find any endometriosis that could be causing your pain, but I think we can address all these other pain generators. But there is so much attention and focus placed on endometriosis as a condition that if you don't have that condition, you can actually feel less validated and less recognised as someone who should have needs for pain care. And I think I know some countries in the world are giving women menstrual leave if they've got a diagnosis of endometriosis, but they have to have that written diagnosis and a letter from their doctor to say they have endometriosis. But does that mean that if you don't have that label, that you then can't take advantage of those extra, options that are given to people who have that diagnosis and have that label given to them? So I think we really have to be aware as clinicians that for people who don't get the label of endometriosis or don't have the diagnosis of endometriosis, that they still need pelvic pain care.
Yes.
And that all pelvic pain care is not just endometriosis related.
How true. When I scan, it's so fascinating. Telling somebody that they have the diagnosis is this moment of relief and validation, and there are often tears of catharsis, I think. When I have a normal scan patient, these are the hardest ones to tell their scan is normal. I quickly say, everything looks normal. Your pain is real. Your experiences are valid. Just because we haven't seen it on today's scan doesn't mean that you're making it up. It's not in your head. I have to quickly say this. But, I think it's almost like we hear in the oncology space, the second you tell somebody that they have cancer, they're narrow mind, the blinders come in and they sort of can't hear anything else after that. It's almost like this experience where I say your scan is normal and they can't hear anything else after that. There's this immense disappointment. And I've not had that many patients surgically where I've had to tell that to, because we do diagnose a lot of people sonographically, and we do have a quite good knowledge of who to bring to theater. But I have seen on social media the disappointment that comes when they don't get the diagnosis. I have heard patients say that they're terrified to have laparoscopy because what if they don't have endometriosis? Then will people believe me? So I think there can be harms to the scan if it's negative and the context is not explained and the validation is not still there. And so that's why I make sure everybody knows, and I write it so clearly in the report, we cannot rule out this patient's pain is still valid and worthy of investigations and therapies. We don't want to disappoint people, but people should be happy to not have endometriosis. It's a chronic, incurable, systemic inflammatory condition. There's association to cardiovascular and cerebrovascular diseases. It's a good thing to not have endo. It doesn't mean we can't help you. Yeah.
And it doesn't mean that your pain's not real.
Yes.
Just because you don't have endometriosis.
Yes.
And I suppose focusing, and again, talking about the pelvis as a whole and all the ways we can approach pelvic pain, utilising our allied health colleagues, physiotherapy, dietitians, psychology is so important to look at pain at all angles, and whether you have a diagnosis of endometriosis or not, really looking at the person as a whole and how we can give them the best pain-free future going forward. Looking to the future, where do you see the evolution of the detection and management of endometriosis and pelvic pain going forward over the next 20 years?
Oh, 20 years. Well, as I referenced, I have my career aspiration is to get the probe in the hands of every gynecologic surgeon who's operating on endometriosis. And I'm pretty persistent. So I expect that in 20 years, that will be the case. That gynecology will be more or less the equivalent of what we know as the maternal fetal medicine specialist. Ask an MFM now, could you practice without an ultrasound in your office? There's no way. Ask in 20 years a gynecologist if they could practice endometriosis or complex gynecologic surgery without an ultrasound in their office. The answer will be no way. This is where I think things are going to go, not just for endo, but for adenomyosis, for fibroids, for intracavitary pathology, Mullerian anomalies, ovarian cystic lesions. This is where things are going to go because the tool is just so incredibly dynamic and accurate when it's done by the right people. And this is not even acknowledging that we will see immense evolution in the technology, the accuracy of the imaging will for sure increase as the resolution of imaging enhances with time. And I really have a lot of hope and optimism for the space of gynecologic pathologies, because I think ultrasound will become the biggest revolution in care. And I hope that with time, we're going to be able to identify most of these pathologies early in people's lives, understand what the risk factors are and how to tackle them at a younger age, at a more rudimentary disease state where we can prevent people from having severe endometriosis and irreversible infertility because the tubes and ovaries and bowel are completely fused to each other. I really do think there's so much optimism for endometriosis care, and that's going to come at the hands of the surgeons who are holding the probe.
I like that. We haven't talked at all about medical management of endometriosis. We've touched briefly on hormonal options. Do you think the hormonal management of endometriosis is evolving as well? What spaces are we watching there?
So from my lens, one of the things that I do is I try to identify, again, these concurrent pathologies. So one of the most recent interests of mine is the interface of endometriosis and PCOS. And we're actually seeing quite a big overlap in this. And so when I'm seeing these people in the office, we talk about endometriosis being an inflammatory state. There's an inflammatory state of estrogen as well with people who have a bit of a hyperestrogenism state. And so we want to manage both conditions. Surgery is not going to help PCOS unless maybe we go back in time as well and start ovarian drilling, which I don't know if it's happening anywhere in Australia, but some of my American friends have talked about doing it. But we have to think about what are the concurrent diseases. And hemorrhagic cysts are the other great example. People with endometriosis form these. They're incredibly acutely painful. So I do use a lot of hormonal therapy. I use it in a really strategic fashion, trying to target not just endo, but all of the sidecars. What's happening? Amenorrhea is such a fundamental state for a patient with endometriosis because menstruation is a point of inflammation. It's a point of pain. And even though the amenorrhea is not actually treating endometriosis at all, it's treating one of the concurrent pain generators. So when I'm trying to not necessarily always preoperatively, sometimes even postoperatively, help people with the overlapping pain conditions and help them have an opportunity to do the pain science work where they're retraining their muscles, retraining their nerves. I talk to them about suppressing these pain generating episodes, bleeding, ovulation in particular, because every time that they have one of those episodes, that pain system is reactivated. And if they're doing the work, if they're doing physio, every time they have one of these events, they're knocked back. And it's so difficult to do the work if you're having an acute pain episode. So I try to use hormonal therapy in a really nuanced way to target the concurrent events, the events that are limiting their ability to retrain their system. And then in some patients, a simple use of a progestin medication helps a lot of their symptoms, and they don't want surgery. They just are happy to use that progestin and go to work and have a family. And well, they're not actively having a family on the progestin, but be with their family. And so it's always individualized, right? But we do have some newer medications available. The GnRH family is a growing family. And that family in particular, I have a lot of thoughts on, probably a whole podcast on overall, but I try and use them very strategically in the patients who are in the perimenopausal age group. And I also try and use them in a way that can be a respite for patients to work on those pain system changes when some of the other hormonal agents may just not be sufficient to stop these pain generating events. But I don't often use the medications like Rieco or Elagolix or Lupron in a long-term fashion because I just don't think that they're sustainable often from a side effect perspective.
I think we're still lacking some of the long-term data on some of those medications as well. So again, another watch this space as to where the hormonal management of endometriosis is going to progress.
Yeah.
I think we've covered so much. I have so many more questions I'd love to ask, but I know that the clock is ticking. You need to get back home to Canada. So on that note, a huge thank you for your insights, Mathew. This has been a great conversation, lots of food for thought for clinicians, whether they're laparoscopic gynecologists, sonologists, gynecologists, or any of our other listeners. And so thank you so much for joining us today.
Thanks for having me again. It was a wonderful conversation.
You can explore a variety of clinical resources about endometriosis on the RANZCOG website, including the full guideline, a quick reference guide for primary care, and a free e-learning module. There's also information available to support patients too. We've included the link in the show notes. If you've enjoyed today's episode, please rate, review and subscribe. And while you're at it, why not share the podcast with a colleague? It's a great way to help others find Talking O&G. Don't forget you can claim up to 1 hour under educational activities for listening and 1 hour for outcome measurement or performance review for answering reflective questions. The link is in the show notes. We'll be back soon with more conversations on the issues shaping obstetrics and gynaecology across Australia and Aotearoa, New Zealand.